Hi, welcome back to educator.com. This is the lesson on the female reproductive system. So if we start with the external genitalia and what the parts are called and what they function as, the first one I'll mention is the mons pubis, and that's technically superior to the majority of the external genitalia. Usually it looks kind of like a little bulge that is somewhat anterior / superior to the rest of these structures. The vulva, this is one of the most misunderstood terms, especially because a lot of people refer to the entire female external genitalia as the vagina. That's not true. The vagina is actually the passageway inside of it. The vulva is the term for all of these collective external parts together. So this is all the vulva. So as I mentioned a second ago, the vagina is actually the interior passageway. Talk more about that in a future slide. The vestibule is pretty much like the opening or doorway into the vagina. This term has come up in other lessons. If you watch the lesson on the sense of smell in the nose, the vestibule, what you breathe into, that's actually the opening into like through the nostrils into the nose. So the vestibule is just the tissue that actually is kind of the doorway into the vagina. The clitoris is superior / slightly anterior to the vaginal opening, and the clitoris is actually analogous to the male penis. So when this particular individual, if she's a female, was developing in the womb, hormonal differences is what stimulate the clitoris to not become a penis, or vice versa. So typically, yes, it's not as large as a penis, but it serves a similar function in the sense that it has a lot to do with sexual arousal. And the amount of nerve endings on the clitoral region are very similar to the amount of nerve endings in the entire penis on a male. So yeah, during sexual contact, sexual intercourse, the clitoris is going to become erect, going to get engorged with blood flow, and that makes it more sensitive. The prepuce is the kind of the clitoral hood, and that is analogous to the foreskin on a male. It covers the clitoris. When the clitoris becomes erect, it actually becomes more obvious from underneath that hood. The labia minora line the vaginal opening, and then the labia majora are on the outside of the labia minora. These areas, the labia, are analogous to the scrotum on a male. So if this particular individual had become a male, the gonads, which on a female are going to be internal, would have been stimulated to come down here and end up in the scrotal sac. But on a female, the labia serve a similar function in the sense that they are also very sensitive, and they get engorged with blood flow, and become more sensitive during sexual intercourse. But of course, they're not holding gonads. Urethra. The urethra is technically a part of the urinary system, but we got to mention it because it's right in this area. So you see right here, it says external urethral orifice. An orifice is just a body hole opening into the outside or coming into the body, and that is actually very close to the vagina, but a different passageway. And urine's going to come out of that, of course. And then the vestibular glands. The vestibular glands lining the vaginal region keep the opening of the vagina moist and keep the vagina itself moist. And the vestibular glands are going to make more secretions during arousal and during sexual intercourse. When we look internally at the reproductive organs, yes, the vagina is technically internal because it's the passageway from the opening in the vulva all the way up to the uterus. The uterus, also known as the womb, has a few different parts. One of them is the cervix. So the cervix is labeled here as a separate structure, but technically it's the most inferior part of the uterus, kind of the doorway into or out of the uterus. The fallopian tubes have a few other names. I'll mention those later. Those connect the uterus to the ovaries, and the ovaries are the egg producers. Those make the ova, just like testes or testicles in man would make sperm. So we're going to start with the vagina in terms of the details regarding these internal reproductive structures. It is an elastic muscular tube that extends between the vestibule, remember that opening or doorway into the vagina, and the cervix, which is that most inferior part of the uterus. It's typically 7.5 to 9 centimeters long. That varies, of course, depending on the size of the woman, and the diameter varies. The other thing that's variable is how much it expands. Of course, during sexual intercourse, the vagina is going to change in size. It needs to be elastic for that reason, but even more so during birth. When a baby is coming through that area, it definitely needs to be flexible. Three major functions of the vagina is passageway for elimination of menstrual fluids. So of course, about once a month, when menstruation happens, the vagina is the passageway through which that part of the endometrial lining will be shed. And more details will come up later on in this lesson about that. It receives the penis during sexual intercourse, and it forms the inferior portion of the birth canal. The baby is going to be coming out through this passageway before entering the world. And then the hymen, this blocks the entrance to the vagina until it tears. So this actually separates the vagina from that vestibule opening. And the hymen is epithelial tissue, has blood flow into that particular part of it. And the hymen will be broken during sexual intercourse when an individual loses her virginity. But sometimes, actually oftentimes, when a woman loses her virginity, there isn't a breaking of the hymen and blood loss there, because you can actually break the hymen much before, like years before losing your virginity. Lots of ways it can happen. Just sports, like physical activity, stretching. It can happen while riding a bike. It can even happen using tampons. So the hymen is sometimes broken prior to sexual intercourse, but it is this temporary kind of protective covering in front of the vagina. And here is a mid-sagittal cross-section straight through this part, the bottom part of the female pelvic area, and you can see that a lot of the structures already been mentioned are here. Here would be the labia. You have the vagina here. This passageway is the bladder and the urethra, but here's the vagina leading up into the uterus. And then you can actually see one of the ovaries here and a fallopian tube. This, of course, is the bottom part, or ending part of the large intestine, and you're going to get the rectum and anus. So we look at the uterus in terms of what it's made of, what it's doing. It provides protection, nutritional support, and waste removal for an embryo. The nutritional support part, in terms of the details about that, will be mentioned more in the next lesson after the male reproductive system on the development of an embryo, what happens during those 9 months inside the womb. So yeah, you're going to get development of the placenta and the umbilical cord connected to the baby. And the waste removal has to happen through there too. So the baby's getting its food through the umbilical cord and waste removal through that particular part. So the baby starts out as an embryo, and then once you get to about week 9 of your pregnancy, the term fetus is used until it's born. It's a pear-shaped organ. You can see it's kind of like an inverted pear, about 7.5 centimeters long and a diameter of about 5 centimeters. That's going to be when it's not containing a baby, of course. As the baby develops inside of the cavity of this uterus, it's going to definitely expand a great deal. And the uterus typically has anteflexion, meaning that the bottom or inferior portion of the uterus actually kind of bends anteriorly towards the vaginal passageway. In about 20% of adult women, it has what's called retroflexion, which means it's actually bending slightly backwards, slightly posterior, which has no negative medical consequences as far as we know. But if that particular woman gets pregnant, sometime during her pregnancy, the uterus kind of ends up bending in the anteflexion way towards the front, which is a good thing, I would assume, because the baby needs to kind of be pointed out in the right direction during labor pains and labor contractions. The uterus is anchored by ligaments. There's a wide variety of ligaments. Future pictures in this particular lesson, you're going to see more shots of these ligaments. One of them is called the broad ligament. It kind of looks like a giant, almost like saran wrap kind of blanket all around the uterus and connected to the fallopian tubes and the ovaries. Other ligaments are the round ligament, the uterosacral ligament. So there's several ligaments around the uterus keeping it in place. And it is somewhat posterior in the pelvic cavity, very close to the pelvic bones. Uterine regions, if you were to like talk about the different parts of this uterus, the fundus, like in the stomach, is the top part of the uterus that's actually kind of above where these fallopian tubes start. Most of the uterus is the body, so this entire portion here is the body. You can see right here it says cavity of body. And then the cervix. The cervix is that most inferior part, kind of like a muscular doorway in or out of the uterus. And during sexual intercourse and when semen and sperm are traveling up into here, yes, the sperm are going to end up going through the cervical region, traveling all the way up the uterus and into the fallopian tubes to meet an ovum and fertilize it if they can. When a woman is pregnant, it's very important that the cervix is strong in terms of keeping the baby in here and protected until it's time to be born. Second slide on the uterus, when we look at the different layers in the tissue of the uterine lining, similar to those terms with the heart, you've got peri, myo, endo. So peri, the outermost or most superficial layer around the outside of the uterus. So if we saw a uterus just by itself, you're looking at the perimetrium. That's where those ligaments are going to be attached to. The myometrium, the thickest layer, just like in the heart, the myocardium was the thickest layer. It is, if you zoom into it, all of those uterine muscles. They need to be strong for numerous reasons. You do want that baby to be protected while it's developing, and then when it's time to be born, you need to have a great deal of strong contractions there to get the baby out. And so the myometrium is all that muscular lining. The endometrium, that's going to change over time. Throughout the menstrual cycle, you're going to get sometimes less endometrium and more endometrium. The buildup of the endometrial lining is in preparation for possible fertilization, possible baby being developed inside of the uterus, and eventually the placenta comes from out of there, etc. But if there's no fertilization, the endometrial lining is shed, and that's what causes the period or menses, the menstruation. There are two layers or zones inside of the endometrium, right in here. The basilar zone is a bit superficial, closer to the myometrium, and connected to the basilar zone, you're going to have the functional zone. The functional zone is what's going to be varied in terms of its thickness. So because of these uterine glands found in the functional zone, throughout part of this cycle that we're going to talk about a little later in the lesson, you get a buildup of endometrium, a buildup and buildup, and then if fertilization does not happen, and that will all be shed, and then it starts all over again. The uterine glands will once again create more tissue in preparation for the inevitable fertilization that could happen. The fallopian tubes are also called the oviducts or uterine tubes. All three of the terms are acceptable. Fallopia has some root to Greek mythology. They are about 13 centimeters long, very thin. The passageway inside of them, the lumen of the fallopian tubes, is just millimeters, and they connect the ovaries to the uterus. This is a great picture in terms of the angles at which the fallopian tubes are found. Remember, here's that fundus of the uterus, body of the uterus, and here's the cervix. So here are the fallopian tubes, one on each side. Here's a ligament connecting the ovaries to the uterus, and here are the ovaries. They are hollow muscular tubes, and there are three main segments. The infundibulum is kind of the ending region in terms of being farthest away from the uterus. And so the infundibula would be each of these, and connected to the infundibulum region is what's called fimbriae. So fimbriae are right here. Right here. And they look like little kind of fleshy little fingers almost connected to the ovary and where ovulation would happen. We'll talk more about ovulation in a bit. It's the releasing of an egg into the fallopian tube. And there's actually a slight space, a slight gap between the fimbriae, which kind of make these wave-like motions like this, and the surface of the ovary. And they've taken some amazing videos of the inside of this region. And when ovulation happens for a very short period of time, the ovum, the egg that's released, It's actually called a secondary oocyte, but we'll get to that in a bit. It looks like it's suspended in air for a very short amount of time as it goes from the ovary into the fallopian tubes. And the fimbriae, those wave-like movements of those, kind of help draw it in, accepting that unfertilized egg. The ampulla is right here. Right here is the ampulla. And then the isthmus is kind of that thinner connecting region right here. So here's the isthmus of each fallopian tube. Peristalsis. Peristalsis, we've seen this word before. If you've looked at the other lessons, you see peristalsis in the digestive tract, the esophagus, the small intestine, etc. It is wave-like muscular contractions that are going to be happening in the fallopian tube to help draw the egg into parts of the fallopian tube that are a little bit closer to the uterus. So typically, when an egg is fertilized, it's going to happen somewhere in the fallopian tube. It's possible that it happens in the uterus, but more often than not, it's going to happen in the fallopian tube. So what gets that egg into this region, into the isthmus? It is peristaltic contractions in the muscular lining of the fallopian tubes. The ovaries, women are typically born with two, are paired almond-shaped organs near the lateral walls of the pelvis. And this is a good image from Gray's Anatomy. Here's an ovary, here's the ligament connecting it to the uterus. Like I mentioned before, here's that broad ligament that's kind of laid over all of these internal, female reproductive structures, and it kind of does look like almost like a slightly see-through, but a little bit opaque blanket. The two main functions of ovaries, one of them's a bit more obvious, is the production of female gametes, unfertilized eggs, and they're called oocytes. Secretion of sex hormones. Without ovaries making estrogen and progesterone and these female hormones, you're not going to get female characteristics, what makes females as adults look significantly different than men. You're also not going to get the ovarian cycle. You're not going to get the menstrual cycle. So the amount of sex hormones that are made and secreted from the ovaries are going to initiate those normal female events during the ovarian cycle. Ligaments, artery, vein. So you're going to have ligaments, like I mentioned before, anchoring the ovary to the surrounding tissues. And artery, vein, whether we're talking about the uterus, the fallopian tubes, or ovaries, you're going to see significant blood flow to all of these. Extremely important. You have blood flow to obviously all the tissues of the body, but it's amazing when you actually look at images that have all the blood vessels associated with here. And then the mesovarium is a specific region of connective tissue I wanted to mention. It's right in here. So the mesovarium is this connective tissue that helps keep the ovary anchored in place next to the fallopian tube that it's near. All right, oogenesis is the making of eggs for receiving sperm. And so an ovum, which is the technical term for an egg, the production of those begins before a female baby is born. And I'm not talking about the mother who's pregnant with the baby. I'm talking about the baby's eggs. The process starts while she's in utero, amazingly. It's very different with men. Males do not start producing spermatocytes or sperm until puberty. So yes, they are born with the stem cells they need in the testes, but the amazing thing is that this actually starts in utero for females. So the oogonia, one of them be an oogonium, those are the stem cells that end up making eggs. In males, they're called spermatogonia. But oogonia, the stem cells in a female ovary specifically, undergo mitosis, and if you took biology, that's just regular cell division that's making identical copies, making clones. They undergo mitosis to make what are called primary oocytes between the 3rd and 7th month. And primary oocytes are still diploid. And if you need to look up that term, check out a biology textbook. Diploid means having the pairs of chromosomes. The diploid number for humans is 46, but the inevitable egg, the finalized egg that you want to get fertilized by a sperm, you have to have half the number of chromosomes because you're going to be making half a human with that egg. The other half comes from the sperm. So we need to take the primary oocyte and go through what's called meiosis to reduce that chromosome number in half to get 23 chromosomes. The sperm should have 23 chromosomes, and when you add those together with fertilization, you get 46 again, which are back to the diploid number. So the oogonia undergo mitosis to make primary oocytes between the 3rd and 7th month in utero, inside of the womb. Meiosis begins from these oocytes, but stops. It's arrested in prophase 1. So it does begin, but when a female is born, she doesn't have all those finalized eggs yet. They're all arrested or kind of paused in prophase 1. And each one of them will get kind of restarted. The cycle will begin again to finish meiosis to get to what's called the secondary oocyte. And so when puberty begins, that's when it starts up again. Meiosis will resume. You'll get metaphase 1, anaphase 1, so on and so forth. And then you'll go through meiosis 2, prophase 2, metaphase 2, etc., to make the haploid 23 chromosomes secondary oocytes. But the amazing thing is, meiosis isn't completely finished. It's actually stopped, I believe, in metaphase 2 of meiosis. Once it's fertilized, once a sperm comes into contact with that outer region of the egg called the zona pellucida, once that sperm makes its way in, then the egg's like, all right, we'll finish it now. We'll finish meiosis to receive this sperm, and then, of course, the nuclear parts, the DNA combines to make what's called a zygote. That's the first cell of new life. So it's just amazing how meiosis, it's very drawn out in terms of it beginning in utero and completely completed when an egg is fertilized. So what are these polar bodies? You're going to see on the next slide what these are all about. These are kind of like the leftover daughter cells of meiosis that are not meant to be fertilized. The amazing thing is that meiosis, every time it happens, making those sex cells, you get 4 daughter cells. So when it happens in a man, that one stem cell is going to make 4 sperm that all end up being functional. But in a female, 3 of the 4 cells are not functional. You end up making 1 large ovum or secondary oocyte. And then the other 3 are kind of off to the side, and they are not meant to be fertilized. So let's look at the next slide. Here's a little picture of how oogenesis happens. So here is your primary oocyte that's going to end up going through meiosis to make haploid cells. And in this particular picture, here's the nucleus, and these 4 dots represent chromosomes. So we're to assume that the diploid number is 4 chromosomes here. This is the centrosome, which contains centrioles. They help attach little protein filaments to the chromosomes and help pull them apart to separate them. So here's the primary oocyte, and it's going to start that meiosis process. Here are the doubled, because if you took biology, you know that the chromosome number is doubled prior to division, so now that's why we have 8 dots, and then you get the first division. And here's the first polar body, meaning that from the first meiotic part of meiosis, division, you get one of these it's not going to be a fertilized egg. It's not meant to be. This one will go through another division to help make your mature ovum. So remember, I mentioned that a secondary oocyte is what's released from the ovary. So this is what's going to come into contact with the sperm, and then inevitably, remember when the sperm comes in contact with it, you're going to get that final part of meiosis being done to make the mature ovum. And you can see after this next cell division, hey, we're down to 2 chromosomes. And if you compare that to what we started out with initially, we had the diploid number up here, 4. Here's the haploid number, 2 chromosomes. The sperm, that ends up going in here. Hopefully that has 2 chromosomes if all went well with making the sperm. And then we get the diploid number again when they fuse through fertilization. Here are those polar bodies. Textbooks will tell you that sometimes there's 3 polar bodies, sometimes there's 2. I guess it just depends on the splitting of cytoplasms. But I've read that, hey, 3 happens a lot of the time. So here are 3 polar bodies. The size is actually slightly exaggerated here. I've seen other images real micrographs where the polar bodies are significantly smaller. And one of the theories about why these exist, like why not make 4 eggs from each meiosis? Why only make 1? Well, if you look at what an ovum contributes to that first cell of life, that zygote, it has pretty much all the cytoplasm, all that stuff outside the nucleus. It's going to have mitochondria, ER, Golgi bodies or Golgi apparatus, all those other organelles. And so it's almost as if the cytoplasm that could have been in here is kind of siphoned into this one. It's getting enough cytoplasm in there so that when the sperm comes in, and the sperm is really just contributing a nucleus, just DNA, there's not a lot going on in the head of the sperm. This particular ovum's got all the other organelles that are needed to maintain that new life. And if you look into mitochondrial inheritance, every human being on Earth, what's supposed to happen is you're supposed to get your mitochondria from mom, not from dad. And when we look at the developmental lesson in terms of how embryology happens, I'll mention why it is that you're not going to get sperm from the paternal side. So here are those polar bodies, and inevitably they disintegrate. All right, here's the ovarian/menstrual cycle. Let me explain what these letters stand for and what the parts have to do with. So up at the top here, this is a histology kind of representation of what's happening in the ovary in terms of the follicle developing, and that's why this is an F here. This is the follicular phase. Here's the egg being released through what's called ovulation, and then what's left over of this follicle, this kind of nourishing part in the ovary that helps the egg develop, this is called the corpus luteum. And then we'll talk about what happens to that corpus luteum. Depending on if fertilization happens, this will either remain or it will disintegrate. Here's temperature. I'll come back to that in a bit. This is a little kind of hormone tracker in terms of the relative amounts of hormones. So the higher the line is, the more hormones of that particular type you would see in the bloodstream. This O stands for ovulation. Here's the luteal part of the ovarian cycle. M stands for menses, which is when a woman has her period. And here's the days. Here's the day tracker, 1 through 28. That's the approximate length of the whole cycle. Once you get to 28, you're going to loop back to day 1 of the next cycle. Depending on the month, sometimes it only will last 22 days. Sometimes it could be 32 days. Sometimes women think they're pregnant because they're late, meaning their period has not come as quickly as they expected. And things in your diet, stress in your life, other environmental factors can have an impact on the hormones and the regulation of the cycle. So sometimes menses or the menstruation can happen sooner or later than expected. So looking up at the top one more time, when we look at days 1 through about 13, this is follicular development. And on the next slide, you're going to see the primary follicle, secondary follicle, tertiary follicle. As the days go on, this is nourished. You see a gradual increase in estrogen. That's what OE means here. Here's estradiol or estrogen. As the hormone levels of estrogen increase, you get development of this follicle, which contains the egg. And then once you get to about day 14, when estrogen levels are peaking and you get what's called luteinizing hormone, so it's actually LH, luteinizing hormone, the peak here directly corresponds to ovulation. So once you get enough of this being secreted from up top, remember if you looked at the endocrine lessons, LH comes from the pituitary gland, but it has a big impact on the ovary. So once you get a peak in LH, and FSH has something to do with it, follicle stimulating hormone, you get ovulation. Having sexual intercourse near ovulation time is going to maximize the chances of sperm successfully meeting an egg that's ready and waiting for it. Because ovulation is that day when the egg is released into the fallopian tube, and it takes many, many hours for sperm to actually make their way all the way up there. So oftentimes when people are trying to conceive a child, they will have sexual intercourse day 14, 15, 16 in hopes that's going to happen, because look at the temperature here. Keep in mind, this is Celsius, so the 1 degree jump is more significant than it would be on a Fahrenheit scale. But 36 degrees to 37, you see that once you get to ovulation, temperature gets really close to 37 degrees Celsius, as if the female has a fever. So a couple who's trying to get pregnant, they will take the female's temperature daily until they show a rise, and then that's a good sign that she's ovulating. So that's something that shows the time is right. The other hormones here, you've got progesterone here. So this black line, progesterone. You can see that there is a correlation between progesterone rise and the thickening of this endometrial layer. So down here, this is showing you the relative thickness of the endometrium of the uterus. So all of this here and here has a lot more to do with the ovaries. Here's development of the follicle in the ovary. Here's hormones impacting the ovaries or being secreted from the ovaries. And here we're looking at the uterus lining. So notice that once ovulation has happened, there's a significant increase in the thickness of the endometrium, and it's due to those endometrial glands, those uterine glands. And then you finally get to this point where if fertilization hasn't happened, and keep in mind that this thickening is in preparation for fertilization because the baby's going to come down, the ball of cells, rather, this early embryo is going to come down in the uterus, anchor itself into the endometrial lining, and then the placenta is going to develop, etc. If you get far enough through, to the day 20-something, and you do not have fertilization, what ends up happening is this corpus luteum, this leftover part from the follicle, it stays for a while, and it actually is secreting progesterone. If fertilization does not happen, this ends up disintegrating, and the disintegration of the corpus luteum corresponds to the drop in progesterone, and that corresponds to menses happening. So once you get to day 28, hey, that's the end of this cycle. If fertilization didn't happen, you're going to shed that endometrial layer. It will get built up again the next month. But yes, typically a period or menstruation happens over the course of 1 to 7 days. If we switched it up and said, hey, fertilization happened, the corpus luteum is going to make progesterone, but this will not drop. Once you get to this point in time, if fertilization has actually happened, this has been fertilized, there's going to be certain hormones coming from that fertilized egg, which is now basically an embryo, that's going to encourage progesterone to be maintained and to continue to increase. And this will be maintained and develop further. And that's important. You want this endometrial lining to not be sloughed off, not be let go, because, hey, fertilization has occurred. We want to have the nourishing ability in the uterus for the baby. And so this will actually stay. And one of the reasons why in the first trimester, the first 3 months of pregnancy, a woman gets morning sickness is, she's used to the drop in hormones here and the inevitable rise again the next month. But if progesterone and estrogens keep rising and they're maintained during early pregnancy, that hormone change can create a nauseating kind of feeling in some women. Not all women, but it just depends. So here's the ovarian/menstrual cycle. So menstruation, if an oocyte, secondary oocyte, is not fertilized, the developed thickened endometrial lining is shed. And we saw that, after day 28, it gets sloughed off. And that's just a fancy term for being shed out through the vagina. So only the functional zone is sloughed off. Remember, there's that basilar layer that helps develop the functional zone. But yeah, that's what's shed. And like I said earlier, it typically lasts 1 to 7 days. This is a tampon. That's, of course, going to help absorb the part that's shed. So if we refer back to that particular chart we looked at earlier, the ovarian/menstrual cycle, to summarize the steps that are happening within the ovary, you can divide it into the follicular phase, pre-ovulation, days 1 through 13 approximately, and the luteal phase. Remember, there was that L part. So follicular phase, day 1 through 13. Day 14 is ovulation, and luteal phase was about 15 to 28, and that is post-ovulation. The steps, we saw that at the top part of the chart, Formation of the primary follicle is going to happen early on in the follicular phase. That turns into secondary follicles. And then finally, the tertiary follicle is what is ready to release that egg from out of it. And that occurrence is ovulation. And then once ovulation happens, that secondary oocyte is in the fallopian tube, kind of rolling along and waiting for a sperm to come up to it if it happens. And then after that, formation/degeneration of the corpus luteum. Remember, the formation and development of the corpus luteum corresponds to the thickening of that endometrial lining through progesterone. And then, of course, it's going to degenerate if fertilization doesn't happen. If fertilization does happen, you're not going to get the degeneration. The important thing about it not degenerating when pregnancy has occurred is you don't want another oocyte being released. When pregnancy has happened, the ovaries stop ovulation for that 9-month period. Menarche and menopause. So the first menses, the first period a woman has is called menarche, and that's usually around age 10 to 12. The textbook I looked at actually said 11 to 12, but I adjusted it to 10 to 12 because over the last 20 years, a lot of research is showing that women are having their first period earlier and earlier compared to the past. And there's a lot of explanations for why that's happening. There are some theories that hormone treatment of our foods, certain chemicals in our diet are triggering menses to happen earlier in some young women. Of course, it can happen prior to this. There are girls who will get the first period when they're 8. So some of it is genetics, from your parents in terms of influencing when that's going to happen during puberty. And there might be environmental triggers as well. Menopause is kind of the opposite of menarche, meaning it's when menstrual cycle is finally coming to an end in terms of having monthly menstruation. So menopause usually occurs between age 45 and 55, but that varies as well. Some women will get early menopause, even in their 30s. That's rare though. 45 to 55 is typically the prime time for this happening, and you get a drop in hormones being secreted from the ovaries that has a big impact on menopause occurring. One of the symptoms is hot flashes, which you may have heard of. The hormone changes in a woman's body and other chemical factors can make her feel like it's really hot during certain times of the day, even when it's not. She might be in a room with a bunch of other people who are not going through menopause, and it's 21 degrees Celsius in the room, but she feels really hot and sweaty, and that's one of the symptoms of menopause. There are treatments for menopause. Some of it is hormone treatments, like taking supplements that mimic the action of estrogen, but you should talk to your doctor before doing that, because there is a slightly higher risk of getting certain cancers from that estrogen treatment during menopause. And here's a couple other reminders of what we talked about. Here's the mostly internal anatomy of the female reproductive system. Here's, of course, the superior portion of the vagina, uterus, fallopian tube, and ovary. Here's another simpler version of kind of the hormones associated with the ovarian and menstrual cycle, and that endometrial lining that builds up and will either be shed or maintained depending on whether or not pregnancy has happened. When we look at breast tissue in a female, that's one of the typical female characteristics, is having breasts more so than a man. So breast tissue, you've got a pectoral fat pad, which is most of the contributor to breasts being larger on a female rather than a man. So that fat pad is underneath the skin, of course. The nipple and areola are two different structures. The nipple is that oftentimes projected part of the breast, and that's meant to be projected because it's something for the baby to latch onto with his or her mouth to receive milk. The areola is the region surrounding the nipple, kind of like a concentric melanated portion. So it's either a bit more red or brown depending on the female than the surrounding skin. So the areola is surrounding the nipple, that projection. The mammary gland itself inside, you have a vast network of lobes. So all of these parts here that look like little sacs, these are lobes that help to actually produce the milk. So you do have glandular structures in here through which milk is made and comes into the lumen of the lobes here. The lactiferous ducts would be, let me highlight that in yellow, these right here. Here are the ducts. Remember ducts, like when we looked at ducts associated with the gallbladder. They're like little tubes that help carry a hormone or substance, usually from some kind of glandular secretion. And in this case, it's milk. The lactiferous sinuses are these regions. All the ducts pour into these sinuses, and of course the sinuses are filled with milk, and then once the baby latches on and starts suckling, you're going to get milk coming out of the sinuses through that opening in the nipple. And I actually mentioned with endocrine system lessons about hormones in terms of just the mother hearing the baby cry can trigger lactation. It can actually trigger milk coming out of the nipple just from the baby crying. And stress levels, nutrition, in terms of what kind of diet the female is on during breastfeeding, can have an impact on milk production. If a woman is stressed enough, she can actually stop making milk completely. And there are formulas out there you can buy instead of breastfeeding that have a good nutritional content for the baby. But doctors will tell you that nothing really beats breast milk. Breast milk is the natural way to nurse your child. Not only is it nutritious, but it does have something to do with bonding there, and you do get antibodies and immune benefits that go into the baby's body through breast milk. Female reproductive conditions and disorders. Amenorrhea is basically not having a period, not having menses occur. So this either means that a young girl has not had her first menstrual cycle prior to the age of 16, or it could mean that an adult who has been menstruating about every month, it stops in her. And there are various reasons why this could happen. Amenorrhea can happen if a woman is anorexic, having a very, very low lipid count. The fat in the body makes it impossible to have the menstrual cycle keep going. You actually make a lot of sex hormones from fat in your body. And if you're not taking in enough fat, and if you're way too thin in terms of body fat percentage, that can stop periods. Dysmenorrhea is actually painful menstruation. And there are treatments for that to relieve those symptoms. Endometriosis is a really crazy kind of disorder. Endometriosis is abnormal development of endometrium, that inner lining in the uterus, outside of the uterus. Usually it happens somewhere else in the pelvis. Usually it can happen in the ovary portion. It could even happen in the fallopian tubes, but endometriosis can make a woman infertile. It's possible, but there are lots of treatment options. It's very painful when it happens, but endometriosis is something that can be fixed. STDs, there are a lot of sexually transmitted diseases out there, of course, gonorrhea, syphilis, herpes, etc., and they can have a huge impact on female health and her ability to conceive a child. HPV, human papillomavirus, or the virus that causes genital warts, can actually lead to certain cancers. So there are vaccines out there for that. Pelvic inflammatory disease is massive swelling of the fallopian tube region specifically. This is something that can be treated if it's like a bacteria that's causing PID, but it can make a woman infertile if it's not treated. Premature menopause. There are lots of reasons that can happen. It could be certain drugs the female's taking, lack of nutrition, environmental factors having an effect on her hormones. But premature menopause, hey, if you're having the stoppage of the menstrual cycle prior to being in your 40s, that would be considered premature menopause. And then here are three major cancers that face women, especially middle-aged, older women: ovarian cancer, cervical cancer, and breast cancer. I don't mean to say that young women are immune to these things, but these, if not treated, are deadly. Cervical cancer has been linked to, like I mentioned earlier, HPV. And there is a vaccine that makes a woman, not get sick or not get HPV, and then you're less likely to get cervical cancer. So a lot of cervical cancers are linked to that virus, not all of them. It's possible to get cancer of the cervix without that virus. Ovarian cancer, if it's caught early enough, they will remove the ovaries entirely, and because removal of the ovaries means that you're going to be producing less estrogen and progesterone, hormone supplements can replace what you're losing there. And breast cancer, getting mammograms is a great way to lower the risk of getting breast cancer. So if there is some kind of growth, they will remove it. Sometimes removal of the entire breast has to happen as a safety precaution. A hysterectomy is removal of the uterus, and a hysterectomy is going to mean that you're infertile. You can't hold a baby anymore, of course. So hysterectomy, if there are abnormal growths in the uterus, a lot of fibroids that could potentially cause health concerns in the female, or if there's growths that look to be malignant, they look to be like you might be having a uterine cancer, they will remove it. It's unfortunate that woman can no longer have kids, but better that than death. And then tubal ligation is how a woman gets fixed. If a man wants to stop having kids, they'll do what's called a vasectomy, which we'll talk more about in the next lesson. But tubal ligation, much more serious kind of operation, because you have to put the woman under full anesthesia, because you have to go inside the abdominal cavity. And they go in and they physically cut the fallopian tubes, solder the ends, meaning they kind of like seal off, like sort of burn the edges shut, so that, yes, an egg will continue to be released out of an ovary, but sperm will not be able to meet it in the fallopian tube. So it's a way that a woman can stop the chances of getting pregnant, but it does have a slight risk of fatality. Every surgery where you're being put under full anesthesia comes with that risk. With a man, it's an outpatient procedure, meaning it's very simple. They do a local anesthetic. It takes like 30 minutes or less. But tubal ligation is an option for women who want to stop having children. Thanks for watching Educator.com.